a study on characteristics and outcome profile of hospitalized African patients with COVID-19, the Ethiopian context. This is one of the articles that we wrote. And just to show you the results, here we have presented the socio-demographic, clinical, and laboratory characteristics of the participants and censoring status. It's partly survival analysis. So you have to present all the study population characteristics. It's very important. And since this is a novel condition, we did not calculate sample size. We have included all eligible participants because we want to learn more about the condition, and we're not in a position to calculate sample size and just remove the others, because we can't say that the sample population has similar characteristics with the other population because we have no idea about the entire COVID-19 patients in our country. So we have included eligible 1,741 patients, and among them 71 died. That makes the prevalence of death 5.3%. So we have 5.3% death by proportion, and the other we have assessed factors that are associated with clinical recovery. You might not want this. Yeah, so here we have a table, regression table, that shows the association of the exposure, these exposure variables with our outcome. And as you can see, fever and disease severity and having cough, and these three factors were significantly associated with our outcome. And so our discussion should focus on, even if we have all these results, these are like supplementary results which we can use to further characterize or discuss our findings. But the main focus of the findings should be based on our outcome variable, the magnitude of the problem, which is the rate of death, 5.3%, and the significantly associated factors, as you can see here, fever, COVID severity, and cough. So there are two regression analysis. That's why I'm skipping the other. If you're interested, you can read this on your own. So the discussion section starts by describing what we have done, how many patients we have included, and others. And we presented the death rate. Since people want to see how precise our result is, we put the confidence interval for the outcome. Otherwise, we don't put confidence intervals, adjusted, p-values for other results. So when we discuss our results, I think you can read this paper. The link is on the slide as well. The number was like high compared to some studies, and it was very low compared to another study. So before jumping to the conclusion that there is a high rate of deaths in our country or in our institution, we have to compare, we have to see the characteristics of the studied population. As you can see in this example, there was another study in northern Ethiopia by the time this study was published. So we have compared it with that. The death rate in that population was 0.8%, but in our study it was 5.3%. But we can't say that the death rate was high, because first we have to compare the characteristics of our study population. In our study, we had a considerable number of severe patients, like up to 23%. But in the other study, they did not have, almost like 4% severe cases. So whenever you have more severe cases, the risk of death also increases. So considering that the study population in the northern Ethiopia study was like very stable, asymptomatic patients, we don't even expect there to be deaths, right? And on the contrary, when we compare it with other studies, for example, like in New York and other US countries, their death rate was very high, like up to 23%, and others. But their admission pattern was geared towards admitting severe and critical patients. But in our setup, even mild, moderate, even asymptomatic patients were admitted. So before saying that our death rate is lower, then we have to explain that what we have studied is mostly mild and moderate cases, with up to a quarter of them having severe disease. But in other setups, 100% of them were like severe and critical. So if you consider that, we can say that even the death rate in our setup is higher, considering that the study population was relatively healthier. So the characteristics of the study population is relevant in contextualizing our finding while we compare it with other studies. And the other is when we present our study results, as you remember, the first one was temperature, and then the second one was disease severity, and then lastly it was cough. So we have followed the same presentation flow, and we presented our finding, and we have presented it in the context of what's already known, why having fever was associated, what was its implication. Is it because it shows a competent body defense system, or why was there a significant association? Even for severity, for cough, for everything, you have to present the available evidence, support it with current policy whenever possible, and compare it with other results. And when you do that, before rushing into judgment, to say that our result is good or bad as compared to the others, you have to consider the study population characteristics. If they were not comparable, we can't say that our result is good or bad as compared to the others. So these are some of the things that you can